My dear students, in this video, I'm going to discuss another common problem in the ICUs these days is azole-resistant candida infection in the ICU. This is something which was not so much common there a decade ago, but has subsequently been becoming commoner and commoner, and sometimes it becomes difficult to decide upon the appropriate antifungal therapy. Now, let us start with this case. A 65-year-old male, post-operative day 7 after emergency laparotomy for perforation peritonitis, is ventilated in the ICU. He has a CVC, is on TPN with broad-spectrum antibiotics, and has been receiving fluconazole 400 mg per day empirically for persistent intra-abdominal sepsis. Over 48 hours, he develops new fever spikes, hypotension requiring vasopressors, and rising inflammatory markers. Blood cultures drawn from both central and peripheral lines later grow east, and direct identification suggests null albicans candida. So, what is the cause of this problem, and what is the solution? Where lies the solution? Although it is difficult to give a mathematical solution to such problems, but at least there are ways to find the best solution in such cases. So we have to understand that this is a typical case of breakthrough candidemia, which was discussed quite back, that is around 7-8 years back, exhaustively in this paper, which was published in my courses. So as we know, breakthrough candidemia or breakthrough invasive candidiasis is the development of candida bloodstream infection or other invasive disease while the patient is on systemic antifungal treatment or prophylaxis. Now, as in our case, we have seen that the patient was already on fluconazole because of intraoperative sepsis. So even this patient is developing bloodstream infection because of candida. So this is what is breakthrough candidemia. And this breakthrough candidemia is associated with substantial mortality. And that is what we practically see in our ICUs whenever such patients develop candida infections. They have a higher mortality in comparison to the other control or the cohort. So the clinical reasoning might be that in this context, several high-risk features converge. And like in our patient, prolonged ICU stay, recent abdominal surgery with ongoing sepsis, central line, TPN, broad-spectrum antibiotics, and crucially, the ongoing fluconazole exposure. So these factors make azole-resistant non-albicans candida, which are like glabrata, cruzi, oris, very likely. So continuing fluconazole is inappropriate because this is breakthrough candidemia on azole therapy, and it is a red flag for resistance. So we have to know that which organisms are of particular concern in such situations. Now, if you look into the common resistant species and the patterns, we can see that Candida glabrata is one of the important causes. And the resistance, that is candidemia, the breakthrough candidemia, due to Candida glabrata is frequently dose-dependent or frankly resistant to fluconazole, may have cross-resistance to other azoles, including vori. So it has reduced susceptibility to echinocandins nowadays. So it is going to become one of the challenges in treatment. Candida krusei is intrinsically resistant to fluconazole, and it has variable susceptibility to other azoles. Good that at least other azoles, including voriconazole, may work, or the isavuconazole may work. The Candida auris is often multi-drug resistant, and it is increasingly, hugely in many parts of our country. There are reports we are coming across in the literature, and many of these Candida auris isolates are resistant to fluconazole and sometimes even to multiple azoles and even amphotericin. So echinocandin often retained, but even with echinocandin, the resistance is reported. So this is also a very challenging bug in terms of treatment. Candida parapsilosis is classically azole susceptible, but there is increasing fluconazole resistance and reduced echinocandin susceptibility, and that is being reported. So these are the four common species that we know, although there are others too. But literature supports these four species. Literature identifies these species and supports better therapy in case of this species if there is breakthrough candidemia. Now, if you look into this article, which was published from India not so long ago, about azole resistance in candida infections among critically ill patients, we see that if you with fluconazole, voriconazole, amphob, caspofungin, as you can see that there is candida albicans was around 9.4%, with tropicalis it was 10.3%, lower with glabrata, parapsilosis, etc., where non-albicans species had 3.2% of the resistance. So the overall resistance rates in blood isolates for fluconazole were reported to be 21.4%, and although it was much more than that with voriconazole, 5.6%. So although we know that these figures can vary sometimes in different centers depending upon the center, because in some places, in oncology centers, these rates may be high, because in oncology setup, we know that the resistance to azoles is much higher in comparison to the non-oncology counterpart. And if you look into the antifungal resistance for blood isolates, there also we can see a particular pattern which applies to azole, amphotericin B, and echinocandin drugs for the isolates. And if you look into the non-blood isolates, there the pattern is a bit different, because amphob and caspofungin, they show a different numbers. The number game just switches. As we can see, the amphob becomes much higher in comparison to the echinocandins. So if we look into this study, they have shown that the trends of resistance to azole antifungal drugs over time, and this is important because the trend of azole resistance from 23 to 2025 increased for azole from 18.5% to 34.6%. That means nearly one third. And for voriconazole, from 5.7 to 10.2%, that is nearly doubled. Echinocandin resistance was not notable. It was still 0.6 to 1.6%. But overall, echinocandin resistance rates were low and steady, regardless of the sample type. So this study showed a significant increase in antifungal susceptibility testing volumes over the study period, reflecting the growing clinical burden of the Candida species, and the potential rise in the azole group of drug resistance was because of the use of azoles, overuse or use, and there is an understanding that there is a need for continued regional surveillance to track the resistance strengths. Now, what the diagnosis and when to suspect azole resistance? There are certain clinical clues in an ICU patient with suspected or proven candidiasis, that is, prior azole exposure with persistent or breakthrough candidemia while on fluconazole, isolation of high-risk species, the ones which I've mentioned, from blood or sterile sites, persistent colonization or infection with candida despite adequate fluconazole dosing and source control. And the diagnostic approach in those patients beyond routine blood culture should be species identification and susceptibility testing using broth microdilution or commercial panels, because these are important for tailoring the therapy. So use of non-culture tests like beta-D-glucan can support diagnosis, but although they do not distinguish resistance. So they guide initiation of the drug, but not quite the choice of drug. If we go to the ICU management therapy with empiric or initial therapy for hemodynamically unstable or high-risk ICU patients when suspected with invasive candidiasis, especially with prior azole exposure or unknown species, still echinocandins are the first line, any of the ones which is used in the hospital as per the local antibiogram can be used. Liposomal amphoby is preferred if prior echinocandin exposure is there, suspected or confirmed Candida auris with reduced echinocandin susceptibility, if the patient is having severe sepsis with MODS where rapid fungicidal activity is prioritized, or if in that area the local high echinocandin resistance rates are there. You have to remember that de-escalation to fluconazole or voriconazole is considered only if the isolate species type is wholly typically azole susceptible and the susceptibility testing confirms low MIC, patient becomes clinically stable and there is no prior significant azole exposure. Otherwise, we continue with echinocandins. For targeted therapy by species, for Candida albicans, Candida tropicalis, if they are azole susceptible, in those patients also, if there is breakthrough candidiasis, you start echinocandin in the ICU and step down to fluconazole if patient is stable and the reports match susceptibility testing. Candida glabrata, you use echinocandin, consider step down to high dose fluconazole or voriconazole if only MIC supports and the patient becomes stable. Cruzi, echinocandin or amphoby, fluconazole is not an option or for stepping down at all. In Candida auris, echinocandin first if it is susceptible, amphoby or combination therapy if resistance is suspected or confirmed, or in severe disease. So when you encounter suspected Candida breakthrough Candida breakthrough infection, what should you do? First, you confirm that the isolate truly represents infection, that is candidemia, it is not colonization. So repeat blood cultures and look for deep focus like do an echocardiography, fundoscopy, imaging, as the case may be, as per the candidemia guidelines. Immediately reassess the ongoing antifungal treatment. Breakthrough by definition implies failure of the ongoing agent. So switch class from azole to echinocandin or to liposomal amphoby depending upon the local resistance and patient factors. Remove or exchange the intravascular catheters and other removable foreign bodies as soon as feasible, since catheter retention is associated with persistent fungemia and worse outcomes. Always request your microbiological colleague for species identification and susceptibility testing. In settings where emerging echinocandin or azole resistance is there, like glabratus, parapsilosis, heteroresistance, etc., the results should refine your definitive regime. Always ensure adequate dosing and PKPD target attainment, particularly in critically ill patients who have altered volume of distribution or are undergoing extracorporeal therapies. The duration of therapy typically follows standard candidemia guidance, that is at least 14 days after first negative blood culture and resolution of symptoms and signs, but may need extension if there is persistent focus or if the infection is deep-seated. If we look into this study, which was published in 2025, this has re-emphasized that the duration is usually at least 14 days after first negative blood culture and resolution of signs of infection, assuming source control and neutrophil recovery if relevant. Now, one important aspect in this connection is to understand the importance of source control and stewardship. So we have to remember to remove or change the intravascular catheters as early as feasible in candidemia, because catheter biofilm promotes persistent infection and functional drug resistance. So none of the antifungals would actually be useful in that stage. Drain abscesses and manage anastomotic leaks or abdominal collections aggressively in post-surgical ICU patients, particularly who encounter post-surgical complications. Apply antifungal stewardship, avoid unnecessary fluconazole prophylaxis, minimize the duration, and use echinocandins judiciously, always to delay resistance emergence. The prevention and infection control in the ICU is very important to deter this process and prevent this phenomenon from occurring. So always remember, we have to restrict routine azole prophylaxis, and this should only be confined to very selected, well-defined, high-risk group where we also have to monitor the local resistance trends. Enforce strict catheter care bundles and central line insertion or maintenance protocols to reduce candidemia. And for Candida auris and other MDR Candida, implement contact precautions, single room isolation if possible, and enhanced environmental cleaning because of high environmental persistence. So at the end, my take-home message would be azole resistance candida is emerging ICU threat. It is driven by widespread azole exposure and rising non-albicans species. Empiric therapy in critically ill patients should favor echinocandins, not fluconazole. Prior azole use, prolonged ICU stay, TPN, abdominal sepsis, central lines markedly increases the risk. Early species identification, susceptibility testing, catheter removal, and surgical source control are extremely important and crucial. And last but not the least, antifungal stewardship and strict infection control practices, especially for Candida auris, are absolutely essential. So thank you very much.